Well, good morning, everyone, and thank you again for Abdullah and for Waz and all the organizers for the opportunity. Yes, I'm going to talk to you about aortic coronary dissection. I whistle tour again, and I'm sure there are some cases that will be presented that will also highlight how we treat them, how we manage them. So what I'm going to do, just some definition, classification, look a little bit of literature and how we manage them, and maybe couple cases. No, I'm not going to show cases with live images, just still images to illustrate how these are managed, and I'll leave the cases also, the live one, to show how this is. I mean, it's no surprise. It's like persistent contrast staining in the aortic cusp or root. We all have probably seen it, and we all have dealt with it. And it is potentially catastrophic because it depends on where the dye comes and how it affects the aortic valve. It can lead to really severe AR. It can lead to cardiac tamponade. Depends on where the dissection and where the effect on the aorta happens. And can lead to emergency surgical aortic repair, bypass, and in rare occasions, even death, if it's not treated correctly and efficiently. The frequency is reported between 0.07 for PCI and 0.02 for diagnostic catheterization. And surprisingly, in this publication, that was probably about 10 years ago almost now, there was significant association with PCI for acute MI. Now, you start to think about why we had acute MI, and you probably, because we all know that MI happens, we all get that rush, you want to go do things quickly. And maybe this is why this happens. I'm not sure, but I'll be interested to see what people's experience is. But just intuitively, you would think with acute MI, we all know how the system gets activated. Everybody's rushing, oh God. And really, it doesn't make any difference. 5 or 10 minutes doesn't make too much difference. Because remember, the patient doesn't present to you for 2, 3 hours, 4 hours. But we get that urge, and everybody is just rushing to do things quickly. And maybe this is why this happens. So I could see where this would come from. And there's a kind of classification that was proposed by Dunning. This was published, I think, about 2000. So a long time ago, they did some review and came up with this dissection being limited to the sinus of Valsalva, or the one that extend into the aortic wall, less than 40 millimeter, and the one that extend more than 40 millimeter. And this is the one that's more significant, because when they looked at the study, the dissection that extended more than 40 millimeter, this one, the one that was associated with the poorer outcome, and some of these patients have ended up going for surgery. Now, we could argue whether surgery was necessary or not, but a lot of people get panicky and do this. There's another classification. This is in the PCR textbook. Again, putting it as class 1, just ipsilateral aortic cusp. Class 2, extending up to less than 40. So more or less the same classification, but this is, they put it class 1, 2, and 3. And they're all type A, obviously, because of the ascending aorta. And it can occur independent of a dissection extending from the coronary artery. What that means, you could still have dissection in the coronary artery, or the coronary artery is still intact, but yet you have the dissection in the cusp, in the ostium extending to the aorta. So it's important to make sure that to understand this, it's got nothing to do with the coronary artery often. It could be just the aorta and the ostium extending to the aorta. And I mentioned this yesterday, and again, this was reported to be the most important or most predominant cause for aortic dissection or coronary ostial aortic dissection. It is the manipulation of the guiding catheter or the diagnostic to that effect without guide wire. And again, you could understand the mechanistic of this when you're trying to move the catheter around, particularly aggressive catheter. For instance, AL1 or some of the more supportive catheter that can lead to the dissection of the ostium that can extend a little bit more. And there was a case, I was going to put it in, but I decided to leave it out actually, where a using of AL1 caused a dissection in the cusp of the right coronary artery, right coronary cusp. It didn't look anything sinister, just benign. The patient had an angiogram, then had an angioplasty by one of my colleagues, and 2 hours later on the ward collapsed, and nobody knew what. Everybody thought it was a stent thrombosis, because that was the right coronary artery treated. This was a lady of 83 years old, really small aortic dimension and so on. Anyway, ended up going for a post-mortem, and what the post-mortem showed, a dissection, a spiral cut in the root of the aorta. And when you go back and look at the angiogram, because we discussed all these cases back, you could see the aortic, the AL1 moving around until it cut into the right coronary artery. Surprisingly, using the right radial artery, JR4 has, in some of the publication, has more coronary artery dissection in the right coronary artery more than AL. Again, this is, you could think about why this could happen when you're coming from the right coronary artery, but this is what's been reported. JR4 causes more dissection in the right coronary artery than AL when you go through the radial artery, the right radial, that is. So anyway, manipulation of the guiding catheter without guide wire is the most significant reason, predominant reason why this can happen. And of course, the mortality from iatrogenic dissection originating from the ascending aorta and descending aorta to that effect. Again, some of you might have seen this, and we have seen it on a couple of occasions where 6 or 8 hours later, the patient collapses, and they found at the CT scan that the aortic dissection has propagated all the way down to the descending aorta. Very rare, but it can still happen. So, in another word, this can be quite, it's not a benign feature unless you know that you've sealed the dissection, you've treated it well. So there was a literature review about 107 published cases of aorto coronary dissection. And 75%, 3/4 of them happen in the right coronary artery. Again, I mean, I think I've done this many times, and I haven't seen a dissection in the left. At least I haven't seen it when my hands hasn't happened. I have had many in the right coronary artery. Again, whether this is because of the anatomy, whether it's because of and often the one I've seen mostly during CTO, but it can still happen anytime. In this literature review, about 50% were treated with stents, which is all of us treat right now. Emergency bypass operation about 30%, and conservative about 20%. Now, emergency bypass operation, I can't remember the last time any patient went for surgery. And probably, again, because everything has advanced and we are able to treat these quickly right now, I don't know if this will apply currently, and I'll be interested to see what people will think when we're discussing this. Again, this is the same one that they gave the classification. Look at 43,000 angiogram and BCI, and there were 4 patients who this happened during MI. And this is where they said the dissection can happen more during acute MI. 4 patients of these, more than non-MI. And 2 of these patients have gone for pathology. There was no particular pathology to show except aging. So there's no predisposing factor. But intuitively, again, maybe we don't see enough of these. If you have Marfan, if you have an aortic, a kind of an aortic aneurysm or any problem with the connective tissue, you would think this problem will predispose you more to these possibilities. Again, they reported about another literature review. This is a prospective registry, and they suggested about 0.12% of PCI and less than 0.01 of 26 catheterization. So it can still happen, and I think we've seen a case yesterday with diagnostic. So it can still happen with diagnostic, they're not benign. So again, they showed that all treated by placement of osteal stent. And this is the main thing for us. How do you treat this? I remember just recently I don't think Tariq is here. He was doing a case, and there was a dissection in the right coronary artery ostium. And I get the phone call, this was about 5 o'clock. And I walked into the cath lab monitoring room. There's 3 surgeons, 2 anesthetists, and all the perfusion people, all because the dissection has happened. panic button was pushed and everybody was like, oh, and all what needed to be done just to put a stent in the right coronary artery to stabilize everything. But if you kind of see it, if the patient maybe is hemodynamically becoming a little bit compromised and people are panic, everybody just jumps on the bandwagon, and you have to be really careful how you do this. But placement of an osteal stent is really very helpful and stops this. The main thing is just to stop injecting. That's the main thing. Conservative management, if it's only less than 40 millimeter, is absolutely fine once you sealed the dissection in the ostium. So you could use a single or several stents, and we discussed this yesterday. What do you do first? It's always important to make sure you seal the entry point, which is at the ostium. Once you've sealed the ostium, and make sure you're not injecting very hard. You move your catheter, very gentle injection, and that's the most important thing. If you have a wire down, it's easy. If you don't, often, I mentioned this again just yesterday, if you cause the dissection with the JR, and you find it difficult to get into the true lumen, sometimes changing the guiding catheter, if the patient is stable, obviously, because the direction of the wire, the direction of the guide catheter may help you to get into the true lumen. But once you've done that, you'll be able to stent the ostium. The main thing is to avoid repeated injection. This is the thing that causes the biggest problem and causes the propagation of the dissection. And once you've stented the ostium, it's not going to stop immediately. So in order to avoid moving the catheter back and forth, damaging the stent, and also extending the dissection, you could use a guide liner, a guide extension. Just leave it in the stent so it doesn't have to move. So when you inject, you're not propagating the dissection and you're not affecting the stent. And these are the little steps that could allow you to prevent the more catastrophic outcome. Surgical repair has been reported because people have been referred for surgery. As I said, in the old days, before all this advancement and us being able to deal with this efficiently, 30% have gone for surgery, and the outcome was not very good, especially if the dissection more than 40 millimeter. So ostial left main stenosis, obviously this is just all what we do. You have to make sure that you stop the, you move your catheter. I think something is hidden behind that. Anyway, you move your catheter if the pressure is dampened. It's kind of what we do normally. And you send the ostium, making sure that you cover it. You could use an IVUS if the time allows, if the patient is stable, and to make sure you cover the ostium very well. And you do it in multiple angiographic appearance. And use IVUS to guide the stent if the time allows and if everything is stable. There was multiple case reports. I'll show you this case because this was published a long time ago. This was treated by bypass operation off pump, and it's more than, this was about like 70 millimeter, as you could see. And this is again because you continue to inject, you inject hard, and all what you're going to do is just propagate the dissection. So really remember not to inject and to stop. This was another case also with some images that was sent for surgery. And from the beginning, you could see the little line from the right coronary artery starting to appear. And again, you continue to inject, and this is what happens. It's inevitable because the dye has to go somewhere. And when you're injecting through the small catheter, particularly diagnostic, in fact, you're generating high PSI, 600, 700. So you are going to propagate this. So really be careful with this. And you go for surgery, that's what they found. So it can cause a big problem. It can lead to death even. So in conclusion, really aortic dissection can be massive, accompanied by significant AR and tamponade. And often this is the kind of the alarming thing. The minute you see any effect on if the dissection and the dye is going toward the cusps and the leaflet, you know that this is going to be disastrous. Immediate diagnosis and stenting is the main step in management. You stop injecting, you move your guide, you put the stent in the ostium and make sure you cover it. And then you could use the guide catheter extension to put it inside the stent so you're not causing any more propagation. And really, this is the main thing. If you remember, just avoid repeated injection. The more you inject, the more you propagate the dissection if you haven't sealed it by a stent. Sometimes you have to use mechanical support devices, and rarely, I don't think I've seen so far, because everything has advanced and our experience has advanced and how we manage these cases. Referral for surgery can still happen, but okay. But you know, you have to be, you'll be able to judge what you need to do on a case-by-case basis. And there's a lot of these, the small dissection. If you seal the ostium, you could leave them conservatively, but make sure you manage or you monitor the patient at least for 8-12 hours so this doesn't propagate. With this, I say thank you, and I'm happy to take any questions.